Aetna Medicaid. I did a telehealth visit with her, which is something interesting I'll talk about later. I also did a telehealth with her husband at the same time. She was diagnosed in around 2013 or 14 at our local Raleigh General Hospital when she went in for gallbladder surgery. She did have a history of IV drug use, starting IV drug use starting in 2011, but intranasal starting in 2008. Her husband, you could scroll down a little bit, Mitra, thank you. Her husband, I saw at the same time, and they were both really excited to be getting treated for Hep C. They both had many years of sobriety. I probably have that down here somewhere yet. Since 2017, she had been sober. She had not, to her knowledge, been vaccinated for Hep A or B. She has no other chronic conditions or medications. She's had a tubal. She is in sobriety using Suboxone. I guess that's her medication, sorry. She said she had a little bit of fatigue in general, but she didn't know what to attribute that to, and no joint pain, rashes, no GI symptoms, really was essentially asymptomatic other than her fatigue. The only comorbidity would be history of substance use disorder, and I'm currently using Suboxone. I don't have her dose. She was not immune to hepatitis A, and I would assume that we have started her on vaccines, but I'll get to that later down in the case. She was corn surface antibody positive for Hep B. She was basically on her physical. She had seen her, I mentioned this prior, I'm getting a lot of referrals from my colleagues at New River, which is great. She was at her last physical, those were her height and weight. She's clearly obese, and there was nothing else remarkable on the physical at that time. Yeah, we can look at her labs. CBC values were normal. Yeah, you could stop right there, Mitra, as were many of her other lab values. You can see that her ALT and AST were elevated. Her alk-phos was very slightly elevated. Her APRI was 0.89, which is elevated. She was child Turco-Pugh class A, and MELD score was 6. You can see her iron studies there, and her vitamin D, which I'm sure we started her on replacement. That'll be in my notes at the end. Her AFP was normal. She's HIV negative. Genotype 3 with a viral load of 399,000. Her FibroSure gave her a fibrosis score of fibrosis stage F3, which is interesting to me. I believe that genotype 3 progresses more quickly, if I recall that, than type 1. And her, according to her, her likely most early exposure would have been about 11 years ago. So, you know, that's concerning to me that she's F3. She has not yet. So you could go down to the additional information. So a couple of interesting things about this person and about my practice. I had started seeing people by telehealth because of not so much the pandemic anymore, just because of gas prices. I work at an outlying site. It seemed easier for people to get access to me by telehealth. And so I saw this lady and her spouse by telehealth. But what I find is that people don't come in timely for their labs. They don't, and I really spent a lot of time chasing them down. And so she, at her initial labs, a CBC was not drawn. I don't know why. And so I had to chase her down. So the CBC and the ferritin were, the CBC was from last August, and probably the ferritin as well. She has not gotten her ultrasound, her elastography, and the other interesting, slightly complicating factor is that her husband's labs are still not done, and I haven't been able to reach them by phone. Finally, I sent them a letter, and she called yesterday, or she called this morning when I'm not working this morning, but left a message that she would come in for the repeat CBC and that she was going to get her ultrasound today. I, think it makes sense to try to treat them together. I don't really know what's happening with the husband. They were both really nice, really eager for care. I don't know, maybe it just falls down on the priority list. But at any rate, at least I have had contact with her, and I'm hopeful that I'll be able to get in touch with him as well to treat them both, get his labs and present him soon. I guess, I sent a message to her that we want to start Hep A vaccine and vitamin D replacement, but it appears from this that we have not done that yet, just because of difficulty getting in touch with her. At any rate, I think once I can get in touch with her, I could proceed with using Epclusa or Mavrite, and that there would not be any drug interactions. That's it.
Thank you so much, Jen. Any clarifying questions from the group before we go into the case recommendations and feedback?
Hey, Jen, John, I have a question for you. Did the patient know that her husband had hepatitis B? Is that what I'm hearing? And then, and she was unaware whether she had been exposed? I was just curious if this came as a surprise that she had core antibody positive.
No, they both, let's see, let me try to remember back. They both knew that he was positive. She did, I think at the time I saw her, she did not know if she had had it or not.
Thank you. I'm amazed how many times I see that. Where the hepatitis B being endlessly more transmissible between a couple sexually, and that being one point. Point two, it being completely preventable with a vaccine. And it always blows my mind how I don't know where the miss is happening there from a healthcare delivery or public health standpoint, where we're not vaccinating heterodiscordant couples with Hep B. Now, fortunately, she got vaccinated by natural, or I should say, she got immune by natural mechanisms. But bummer, she had to gamble with possibly getting it to become immune. Yeah. Yeah, and she's pretty young. I think. What did I say? She was 40. I'm sort of surprised anymore in people that they haven't been vaccinated as an infant.
Any other questions before case recommendations?
It's that's and I'm going to go on to that for one more second. It's like pet peeve of mine. We see a lot of people referred for hepatitis B, and I'm always mind blown when I talk to them about their family members. And I say, okay, do you have your significant other or wife or husband vaccinated? And very often the answer is either I don't know or no. And very different than HIV or Hep C, because we have such an effective prevention strategy. So sorry about that. Now I'll be quiet.
It's important.
Thank you, Dr. Gilchrist. And anyone with any other feedback, recommendations, and I'm happy to pull up the case as well if you need to refer to anything. Dr. Gilchrist, go ahead. I see you're muted.
Yeah, hearing none. Jennifer, I was just so impressed when you present. Yeah, and I love that your expertise has become recognized and you become a referral center, expanding access to your area of the state to an expert. And I think everything you said was beautiful, especially how you pointed out that this is genotype 3 progressing more potentially rapidly. Probably having no more than I agree with your calculations, maybe 10 to 15 years of exposure maximum, and already being F3. That sort of usually speaks to genotype 3 being the viral risk factor for more rapid progression. So maybe as we go forward with her, maybe her fatigue will get better. So holding out a carrot to her that maybe that will be a extrahepatic manifestation or a symptom of Hep C that might get better with treatment. And certainly being genotype 3 with F3, urgency in treatment is probably required. And what I mean by urgency isn't like tomorrow, but probably we don't want to wait 5 years. It's better to treat now than let her progress further. Your choices of Mavorite and Epclusa are perfect, and they are your only two choices. Mavorite for 12, Mavorite for 8, or Epclusa for 12. And of course, she will need long-term HCC screening because she's already laid down a bed of scar tissue in the liver. So ultrasounds forever. But great job, and get that Hep A vaccine, and then you're rocking. And hopefully, make sure she picks with a phone. That's the only other warning flag on her case. Is she gonna drop off the radar, which would be a bummer.
Yeah, it's been that's been really concerning to me. I've put in a lot of effort to try to get into, and finally a letter did it. So that's a lesson too. And her husband has to use the same phone number, so that's perplexing. And then, would you wait for me to get his labs and initiate treatment for him, or would you just proceed with her and do the best I can with him?
No, I'd proceed with her and do the best you can with him, and educate her to some degree about ping pong transmission back and forth. And but hopefully they've reestablished with you now, and hopefully he'll get okay too.
Yeah, I think so.
And just to clarify for anyone on the call who's not familiar, we always preach to Hep B co-infected patients, but this is a Hep B co-infected patient who's established natural immunity, so antibody has been developed, so therefore this is not someone you worry about reactivation. So you're done once you see that surface antibody has developed.
Thanks as always, Dr. Gilfus. It's really, I really enjoyed doing this work, and I'm so grateful to the entire ECHO team to have been there for me to learn.
Thank you so much, Jen. We really appreciate that. And the Hub members as well. Thank you, Dr. Gilfus, for the recommendations. And please let me know if my volume's a little soft. I'm happy to increase my voice. So if it's hard to hear me, just flag me down. Jen, any other questions before we go to your second case?
No.
All right, awesome. Let's see. All right, I'll turn it to you again, Jen.
Okay, this lady is a little fresher in my mind because I just saw her last week. Again, an internal referral, which I'm also really proud of my colleagues for screening. And I recently did a chart audit on 6 colleagues and at just routine chronic visits, they were doing Hep C and HIV screening. So that was gratifying to see. Anyway, this is a 56-year-old, again, Caucasian, non-Hispanic female with Medicaid Humana. And I don't think we need to look at the physical. Let me go to the history. She was diagnosed in, she thought it was, it's interesting, she thought it was 2019 at a specialist's office, but I looked back in our records and she had gotten diagnosed in 2018 at our organization. And then I don't know what happened with referral at that time. She has a really long history of intranasal drug use, and then a shorter history of IV drug use. So basically starting intranasal in 1997. And then IV was, I just think it was maybe 2018 to 2020. And she is now sober on Suboxone for 2 years and feels very solid in her recovery, has a supportive partner, a supportive living situation. You could scroll down to those comorbidities. Mitra, thanks. She has a lot of other medical conditions, GI, GERD, diverticulitis. She has fibromyalgia, obesity. She's not diabetic, but she's been advised that she's hyperglycemic and could become diabetic. So she's working on that. Hypothyroidism, depression and anxiety that are stable right now, and she's had a right knee replacement. She does have diffuse joint aches, no fatigue, rash, GI symptoms, anything like that. She was vaccinated for hepatitis B when she was a CNA, and is not immune to Hep A. Her physical, I don't think we need to go back to. There was nothing super remarkable there. There is her social history. She told me that she always liked to ask people about their sobriety. And she said that her grandchildren motivate her. She has a good relationship with them. Her medications are amitriptyline, buprenorphine, levothyroxine, omeprazole, venlafaxine, and she is on vitamin D. And so to me, what jumps out there is the PPI. I'm not so sure about the antidepressants, but I'd be curious to get feedback on those. Let's see. So she was hepatitis B surface antibody positive. And then you can see her, I guess her BMI is just makes her overweight, not obese. And then her labs. It's interesting on this, it appears that she's anemic, and I don't remember that from when I looked at the labs. I'm going to have to go back and it seems like a hemoglobin of 11.1 would be anemic. And I had forgotten that, but her WBC and platelets are normal, good renal function. Obviously her sugar was good this day, normal PTINR. Very, very minimal elevation of her ALTS, AST. Her APRI was also 0.86, which I don't know why that would be elevated, but at any rate, child Turco-Pugh class A and MELT score of 6. And you could scroll down, that's good. I'm gonna have to check on that hemoglobin because her ferritin looks like it's in a normal range. I'm not sure what that's about. Let's see, vitamin D is low and she's on replacement, AFP 3.5, HIV non-reactive, HCV genotype 1A with viral load of 504,000, and her FibroSure was fibrosis stage 0. So let's see, we can go to additional information. I already said she's stable in her recovery. Epclusa or Mavrite, if I did the Epclusa, I would have her take it at a different time of the day. And I guess now that I'm looking, and we've started her on Hep A vaccine. This lady I saw in person, I have ceased and desisted with seeing people by telehealth because it's just torture to try to get them in and get them in timely and blah, blah, blah. So anyway, she was there that day, and also look, I'm able to present her within the same month. So it's nice. So I guess another question that comes up for me as I'm looking at this is that does that APRI score make sense given the fibrosis stage? And I did not get an ultrasound on her. It seems like I probably don't need to, but I would like feedback on that as well. Thanks.
Thank you so much, Jen. any clarifying questions or comments about this case? And everyone is welcome to chime in. All right, and any feedback or recommendations?
Hey, Jen, it's John. Oh, I'm sorry. Was somebody else talking or?
No, that was just me.
Oh,
Sorry, I was giving you the cue to go ahead.
oh, thank you. Sorry, Mitra. Yeah. Yeah. You know what? When I was reviewing this patient's case, Jen, the only thing that was perplexing to me was the APRI as well. So just as a recap, so she's possibly up to 20 years infected. Prior, I should say, major motivations to treat her besides her hepatitis C are potential extrahepatic manifestations of hyperglycemia. Remember that relationship between active hep C and glycemic control / diabetes. They tend to worsen each other. So having poorly controlled sugar will increase the fibrosis, and having hepatitis C will worsen your glycemic control. So they have that negative impact on each other that would definitely add extra motivation to treat. So, you know, her genotype and fibrosis score and all that stuff seem fairly standard. So I agree with your with Medicaid's preference list. You'd use Mavorite for 8 weeks or Epclusa for 12. She the only thing that's perplexing is that fibrosis score. So just two seconds talk on that. What this patient nicely demonstrates is really the preferred approach to gather 3 data points. I'm not saying you have to. I'll kind of go to the answer after this, but when you're stuck with 2 data points, you can't triangulate. So what we're stuck with is a APRI that says scar tissue. It predicts maybe F3 or greater, and a fibrosis score that says F0. And you know, that's about as far away as you can get on the scale of where the truth is. We have no idea. And so you'd love a data point from elastography, or even second repeated calculations of the same value to assist us with the reliability of those 2 divergent numbers. Now, just looking at her stuff, I think she's somebody who just runs a low platelet count. 150 is not thrombocytopenic. It's on the low end. Just by luck, her AST, ALT are in the 50s. So just doing an eyeball test, that's going to put you right around a little below 1 for your APRI. I think she's another one of these ones that we could use a fudge factor approach. Just treat her, get her liver enzymes to normalize, and then document multiple times that you now have a normal APRI. I don't think she's cirrhotic.
We think we lost you there, but I heard you say, I don't think she's cirrhotic, and all that was, yeah, all that was really helpful and makes sense. So I could treat and repeat labs and recalculate the APRI. Okay.
Exactly. That's a non-condoned fudge factor approach that we all use when we don't believe a particularly aberrant value. We do that the fibrosis markers too. Remember, the fibrosis markers can really be kind of skewed by one particular odd marker. Whether it be because the AST, ALT are 300, you know, that can make you look like you have a more pessimistic fibrosis score. Or in this scenario, I think it's because the platelet count is in the low end of normal. And so remember, you're going to be doing that ratio with the APRI, and just because your 150, you're going to be divided by a little bit less than 1. And I'm just doing that in my head, looking at the ratio of AST to what a normal AST would be. So that's where your number's coming from. The APRI calculation is correct, but it's, I think, falsely skewed towards looking pessimistic. So yeah, just treat her, get her looking better, document a good year solid of no more aberrant APRIs, and then you won't have to HCC screen her forever.
Awesome, thank you. It's math. It's just all math.
It's all math. Yep, you're right. It's math and just bad luck on that particular day, what her platelet count was. I bet you she'll look better in the future.
Thank you so much, Dr. Gilfus. Any other recommendations or feedback from anyone
Oh,
else?
sorry. I think the omeprazole, your comment was the only one that I picked up. Rachel, you can correct me if I'm wrong.
Yeah, I was just going to chime in. The psych meds and everything are okay with both agents. So whether you would go with Epclusa or Mavorite, no real concerns there from a clinical standpoint. But like you said, the PPI is going to be the thorn in your side there. But the good news is if that is the correct dose there, the 20 milligrams, and she's not taking any other outside PPIs or anything, that dose is okay with Epclusa. So just remember, per package insert, they say, if they can hold PPIs while on Epclusa, that's the best option. They recommend them to not be given concurrently if we can avoid it. But if they absolutely have to, omeprazole 20 milligrams is that max dose they recommend. And then the weird recommendation for that for appropriate administration is going to be to tell her to take the the Epclusa with food, and then wait 4 hours and take that omeprazole. So I always like to give the patients a specific schedule, because a lot of times they'll hear that 4 hours and think, okay, so I'll take the Epclusa in the morning with breakfast, and then I'll take the omeprazole at night before I go to bed. And really the way they studied it in the kinetics and the recommendation is 4 hours. So if you're going to take them at 6 o'clock when you get up, the Epclusa with your breakfast, then wait that 4 hours and take your omeprazole at 10 o'clock. So trying to get them a schedule so that they understand that. But other than that, no other concerns with her other medications and Mavorite or Epclusa outside that PPI.
Thanks.
Thank you so much, Rachel. And any other feedback about the case, or Jen, any other questions you have about this case?
No, I'm good.
All right, awesome. Well, thank you so much for the two awesome case presentations. And Dr. Bailey, I have your case ready to go as well, so I'll go ahead and pull that up for you. All right, are you able to see that okay?
Yes.
All right, I'll turn it to you then.
So I'm actually a fourth-year medical student with Dr. Bailey, and I'm going to be presenting the case. So this is a 48-year-old woman, Caucasian on Hispanic. She has her husband was treated for hepatitis C recently. She herself is going through smoking cessation, and she has a history of IV drug use, last used approximately 6 years ago. And she's currently on Suboxone and in sobriety for that. Some of her other medical issues are chronic pain, GERD, hypertension, hypothyroidism, and migraines. The medications that she takes are amitriptyline, chlorthalidone, lutein, ibuprofen, levothyroxine, loratadine, nicotine, potassium, Suboxone, sumatriptan, trazodone, and venlafaxine. She is not immune to hepatitis A. She is supposed to be vaccinated for that. She is immune to hepatitis B. She has a height of 66 inches, a weight of 185, which gives her a BMI of 29.9. The labs for her, white count of 11.5 with an ANC of 6.9, hemoglobin, hematocrit of 13.5 and 42.5, her platelets are 287, creatinine 0.9, glucose 130, her PT and INR are 9.8 and 0.9. She's an albumin of 4.7, ALT and AST is 87 and 71. Her ALT class is 218, and her total bilirubin is 0.4. Her total protein is 7.8, and her APRI is 0.618. That gives her a child CARE class of 5 and a MELD score of 6. Her iron studies, iron of 67, total iron binding of 326, and ferritin of 187. Her vitamin D was 33. Her HIV antibody was not reactive. She was a hepatitis C genotype of 1A with a viral load of 565,000, with her serum fibrosis biomarker of F1 to F2.
Awesome. Thank you so much. We love when students present as well. So you did an awesome job, and welcome to ECHO.
Well, thanks.
Yeah, no, thank you so much. Feel free to ask any questions you have, and we'll open it up to the group here, if anyone has clarifying questions about the case before we jump into the recommendations and feedback, please go ahead and chime in. And you're welcome to chat in as well, and I'm happy to read it out loud. All right, and anyone with feedback and recommendations?
Dr.
Dr.
Boyle. Yes,
Okay.
always good to hear from you and your med student. So very good job. The I like the case because it demonstrates the natural history of Hep C and kind of the concerning end of it. So this person potentially only had a few years of exposure, maybe 6 years or whatever exposure, and already has some fibrosis. So if you're looking for motivation to treat, this is precisely who you want to treat. Two reasons, as I was seeing her case. Number one, she's already laying down some fibrosis, which is kind of amazing for 5 or 6 years. You know, that's on the fast end of things. Clearly, she's not done any irreversible damage. You can treat her, cure her, and you won't have to do long-term HCC screening. But definitely somebody who looks like they have a predilection to be in that 2/3 of natural history that will develop some form of chronic liver disease from Hep C. So good job to catch this one, good one to treat. And the other reason to treat her, obviously, well, besides the fact we treat everybody, but the extra motivation is to avoid the ping-ponging back and forth of reinfection potential. Since her husband's been treated, it's a great time to eliminate this virus from that pair bond and be done with it. So anyway, that's the only point I had. Yeah, for her genotype 1, I believe it was 1A, Epclusa, Mavorite, Harvoni, would be options with her limitations of Medicaid formulary. Your Epclusa 12, Mavorite for 8. And the only drug on there I wasn't sure on was the famotidine. And I'm going to, because that can also obviously decrease your, or should they increase your pH in your stomach. So I don't know what that's going to do to absorption relative to the PPI. I can never remember the H2 blockers. Rachel, I defer to you.
Yeah, sure. So if you go with Mavorite, I don't have any clinical concerns here from her medications, but the famotidine is going to be an issue with the Epclusa. The dose is okay. You wouldn't have to make any changes to the dose or the frequency since she takes it twice daily. The recommendation for that with the Epclusa would be for her to take that famotidine with the Epclusa at the same time. With either dose, whether if she's doing it twice daily, morning or evening, that won't make a difference, but to take them together.
Awesome. Thank you both so much for the feedback and recommendations. Dr. Bailey, did you guys have any other questions about this case you wanted to have addressed?
No, I think that was really it. She's a pretty straightforward case. Should have a good outcome.
Awesome, that's great. And any other comments from the group before we move on to the didactic portion? Alrighty, well, thank you so much, Dr. Bailey, and your student. I'm sorry I didn't get your name. What was it?
Oh, it's Ella.
Oh, okay, thank you so much to the both of you. We really, really appreciate it and welcome you to come back anytime you want to present a case again. So thank you. And let's see, Rachel, I have made you co-host, so you should be able to share screen anytime you're ready. So I'll turn it over to you now. Thank you.
All right. Should be on there. Make it bigger, hopefully, maybe. All right, you guys can see it okay? Okay,
Yes.
great. All right, so today I just wanted to go over quickly medication adherence, since we know that with the DAAs, particularly adherence is really important for patients to be able to achieve cure. So just going to talk briefly about some of the different terminology and how we define adherence, and go over some of the different types of barriers and facilitators to some of the adherence. So how can we try to overcome those? And then how we can measure adherence when we're talking with patients to make sure that we're giving them the best tools to make sure that they get cured from their hepatitis. So I am going to go over some of the specific literature that has come out with the DAAs specifically. So the first part of it's going to kind of be general adherence information. and then to go over some of what we've seen with the DAAs and some of those studies that have come out. And then just kind of go over some quick tips and tricks now that we know a patient's non-adherent. What can we do about it to help them on their journey for treatment of hepatitis C? I think everybody is probably pretty familiar that that number of like 50% is usually floated out there for patients being non-adherent to their therapies. And a lot of this literature in information is coming from chronic treatment, but there's a lot of validity to it in the acute stance for the acute treatment of hepatitis C as well. So one of the formal definitions of adherence is the extent to which patients take their medications as prescribed by their healthcare professional. So there is some back and forth in the literature between using adherence and using compliance and what is the most appropriate term. And the WHO has come out with a lot of guidance for this. I think they published it originally in 2003, since adherence is such a concern for patients to reach their healthcare goals and taking their medication. So really the difference is that adherence is, patients agreeing to the treatment with you. So really being engaged in part of that treatment plan, versus compliance really makes it sound like you're prescribing a patient medication and either they're taking it or not. They're just kind of passively going along and following doctor's orders, essentially. So adherence really is supposed to encompass, the patient being engaged and following along with the treatment plan that they have also agreed to. So either way, really what we're focusing on is their medication taking behavior. And then you might also see the persistence kind of floated around there from a terminology standpoint. And really what that is just the length of time between when they started taking a medication and the last dose, which we really look at to see whether or not they completed an entire treatment or did they discontinue early for one reason or another. So that's just a little bit of clarity with those terms. But other important terms that I wanted to bring up really when you're looking at adherence and non-adherence is whether or not it's intentional. Which is exactly what it sounds like. A patient is not taking their medication as they should. So an example, would be they just don't want to. It's very common in, say, the cystic fibrosis population where their breathing treatments take a long time, so they don't want to do them, so they'll skip them. So that's an intentional thing, or if somebody's having side effects to medication, makes them feel funny, they don't take it. So that's intentional non-adherence. Unintentional is something that we see pretty commonly, and that's going to be, I forgot to take it. I meant to. I wasn't not doing it on purpose. I just, forgot to take it. It's not part of my routine. So differentiating between whether or not it's intentional versus unintentional is really going to help you target what your intervention is going to be to help the patient overcome their non-adherence. And I get a lot of questions about, what's optimal adherence? What happens if a patient misses a dose, particularly from a hepatitis C standpoint? So in the literature in general, what you'll see is a lot of like clinical trials and things will cite that they want patients to be at least 80% adherent. Where does that come from? Not really sure. But we do know with other disease states, particularly in HIV, that some of the medications that we do have goals for adherence because what we can see is treatment failures and development of resistance. So some of those specific medications, they do want, greater than 95% adherence rate for those patients because of the condition itself. But in general, for hepatitis C, we don't really know what that number is yet. So that's kind of what a lot of these studies are trying to elucidate when we look at them is what's that goal? What are we shooting for? So I also wanted to go over some of the buckets that the WHO kind of has for their different confounders for things that will affect adherence. So they've got these sort of groups here, patient related. So does the patient have any sort of impairment that keeps them from taking their medications? Does the patient even want to take these medications? Compared to socioeconomic, where is the patient able to read the label? So can they read and be able to know exactly how to take their medications, as well as the cost of them. So hepatitis C drugs are very expensive, and if drugs are expensive and they can't afford it, they're definitely not going to take it, as well as homelessness and transportation issues to be able to get to clinic. There are other limitations that can affect adherence from the healthcare system. So what is their relationship to their provider? Do they have a good working relationship? Do they trust them? Do they feel heard? And do they have access to them? So can they contact their patient or their provider when they have questions or when they have issues and need to be seen? And as far as healthcare system goes, I'm always complaining about the broken healthcare system and the things that I see. So coming up with formularies and prior auths and things that need done, in addition to the transitions of care. So a lot of that being tied together with, you know, what they're getting in the hospital might not be what they're able to get outpatient when it goes under their insurance. So that can cause some problems as well. Then we have the actual treatment plan. So we've got medication as well as condition related things that are the last two bullets here. So if a patient has a disease that doesn't really have a lot of symptoms, then why would they take medication for? If I feel fine, I don't need this medication. And then the therapy itself, is it complex in that there's a lot of pills and it's several times a day? Do I have to have drug monitoring? Do I have to take it with food? How long do I have to take it? Are there going to be side effects? So these are all things that can fall into that bucket of things that can affect adherence. And then I pulled this review article because they did all of the hard work for me, where they look at all the different assessments of adherence. And again, this is general. This is not hepatitis C specific for that treatment, but these are some of the studies that have found that different predictors of poor medication adherence. So kind of eyeballing these, a lot of them really probably make sense to you just from your practice and what you see on a day-to-day basis. So patients, like we already mentioned, with cognitive impairment or other mental disorders do tend to have lower adherence rates for probably a variety of reasons. The asymptomatic diseases that we talked about before, you know, they always say that hypertension is the silent killer. And when patients take medications for their high blood pressure, they feel like crap, so they don't take them. So that's a concern. And then really, you know, what I like to highlight here is the patient aspect, the patient's lack of belief in the benefit of treatment or insight into the illness. So this is where that education piece is really important, so they understand the benefit and why they should buy into the therapy that's being prescribed for them. And then some of the other stuff here that probably makes sense: complexity of treatment, like we've already talked about, and then cost. And from this study as well, this review article, I put this figure up here because I want to highlight, you know, the impact that the dose frequency can have on patients. So what you can see is the center tick marks here are the average adherence rate for each of the dosing frequencies, and then the lines here are the one standard deviation from that. So what you can see here is that the adherence actually decreases as the frequency increases. So twice a day, 3 times a day, 4 times a day. It gets worse and worse, as you can see. So down here, when something is a 4 times a day regimen, the adherence is all the way down to 50% at this point. And just looking at, you know, the eyeball test here, as you increase, you know, pills per day, each increase you have is somewhere in the neighborhood of a 10% decrease in adherence. So that is something to factor in when you're looking at regimens for patients and whether or not they're going to be able to stay on top of their medication therapy. And then, you know, people are always asking me, how do you measure adherence? What's the best way to do it? What's the gold standard? There isn't one. So you're going to see a lot of things in literature and things that you can probably try to evaluate whether or not a patient is adherent to their medication. We kind of group them into direct versus indirect measurements. Direct being things where you can actually directly look and tell whether or not the patient is adherent. So the first one being DOT, or direct observed therapy, where the patient's coming in, you watch them take their medication, and then they leave. So you know whether they're adherent or not because you can see them taking it. This was great. You know, we could do this back in the interferon days when the patients would come in for their injections. Not really practical for us to be able to do in clinic now that we have everyday medication. So obviously the pro here, very accurate. I can see you taking it, but not practical for the patient to come in. Similarly would be therapeutic drug monitoring, which we don't really do for hepatitis C, but we do for other things like anticonvulsants and those sort of things. But this is good because you can actually look at the drug levels and see that the patient is taking it and that they're at the appropriate levels, but it's really expensive and it's not something that's readily available like for the DAAs for us specifically. So those are the direct ones. Indirect being, as the name implies, something we can't really monitor directly in clinic, but we can always just ask the patient, you know, are you adherent with your therapy? This is real easy to do, so there's low cost with it. You're just asking them a question. But the problem is that patients generally only remember like the last 7 days. So it's not going to be an accurate thing if you're only meeting with the patient and able to meet with them, every 3 months or something. I can remember that I took my medication yesterday, but after that, it gets a little fuzzy. So even I'm not going to be a good, person to ask when it comes to being able to recall that. So the limitations with that as well. Oftentimes in clinical trials and even in HIV clinics that I've worked in, we'll do, pill counts where we just have the patient bring their medication in. We'll be able to count how many pills they have and know, based on when you were here last time and how many you had, what you should have is this. So you can really easily do this and identify those issues. The problem with this is that patients will need to remember to bring them in, which oftentimes they will forget, or because they want to adhere and they don't want to disappoint their healthcare provider, they'll just dump out some of the pills and leave them at home and just bring in a smaller supply of it so that it does appear that they're adherent. So it's not going to be accurate from that standpoint. And something that we do a lot is the pharmacy fill information. So I have the example here of the medication possession ratio, or MPR. We look at this a lot to see whether or not patients are adherent from a pharmacy standpoint. It's real easy to calculate because all you're doing is looking to see how many pills the patient has over a certain, say, like month to 3 month period to see whether or not they got their fills on time. But that is not at all accurate of whether or not the patient's taking the medication, right? I could send them their medication every month to the day that they need it and not have any late deliveries. Doesn't mean the patient's actually taking it. You could also look at their clinical response. So this is something that we can do in Hep C, right? We can do a viral load and look and see whether or not that's decreasing. Super easy to do, but that doesn't give us the optimal adherence. They could still be missing doses, but their viral load is decreasing. And since we don't really know what that optimum adherence is in hepatitis C, really hard for us to say like, oh yeah, 1 or 2 doses is no big deal. And the last one is electronic monitoring. This one is basically when they put the electronic, we have the pill bottles themselves or something that attaches to the lid where it tracks every time that bottle is opened. So it's real easy to do because you can download all this information, and I've seen where they use these in clinical trials. However, these are very expensive. We're not really able to dispense these from the pharmacy regularly, and they also do not monitor correct dosing. So a limitation here would be, a patient opens their bottle and they go to take their medication, but the phone rings and they put their lid back on there and they walk away and they never actually took it that day, but it's going to record that they did. Essentially, they opened the bottle. And then on the flip side, a patient may open their bottle one time for a twice daily dose, but bring out both pills and, set the other pill aside, put it in their pocket, whatever, take it for later. So they may be adherent, but this is only going to record one bottle opening for the day. So it's going to appear non-adherent. So again, I can't emphasize enough, nothing is the gold standard. Nothing is going to be perfect. There's going to be limitations to all, but you can use kind of a combination of these to try to assess whether or not the patient is taking their medication. So this is where I want to transition and bring up some of the literature that is specific to our DAAs. So this is a study that was done. It was actually part of the Synergy trials, which was specific to Harvoni when they were trying to assess whether or not they could do a shorter treatment duration than 12 weeks. So in this study, they were looking at Harvoni for 12 weeks. So that's the ledipasvir, sibosavir for 12 weeks. And then what they were also doing were adding additional DAAs to see if they could shorten it to 6 weeks. So this regimen was 2 pills, but it was only 1 time a day for 6 weeks. And then this regimen down here was Harvoni plus 2 additional DAAs. And this ended up being twice daily dosing. So they would take 2 pills in the morning and then 1 in the evening. But these 2 additional outside the Harvoni were only 6 weeks compared to the 12. So that was the purpose of this study that they published, was just looking at the adherence with these regimens. And they utilized 3 different modalities. They did the electronic monitoring system as well as pill counts and patient reports to look at adherence. So I have this snippet from the study here, and you can see the overall adherence rate is still really good. Even with this lower here, it's still at 95% adherence with their DAAs. It's a clinical trial. I don't expect it to be pretty low because these patients are being monitored pretty closely anyways. But what you can see here is that consistently the MEMS in all 3 of the groups is lower for adherence. So it's going to be lower compared to the pill counts and the patient reported. So that's that electronic monitoring system that you see here in black. So you've got regular Harvoni for 12 weeks and then these 2 6-week regimens where you see a slight decrease, where this is to 2 pills once daily, and this one is going to be to 3 pills, 2 in the morning and 1 in the evening. So there's a slight decrease here. So some of the things that they teased out in this publication for risks for non-adherence in the 12-week group was recent drug or alcohol use, which these were bucketed together, drug and alcohol use, and they defined recent as within the last 6 months. And an important thing that I noticed is that they excluded active drug use and alcoholism from this. So these are patients that had been clean before the study started, but they had recently used drugs or alcohol. But they did see in the 6-week treatment that there wasn't a change overall in non-adherence. So the drug and alcohol was specifically to the 6-week treatment, the longer duration. I have more snippets here where you can see some of this information teased out a little bit more. So also what they noticed, which I was kind of alluding to with the MEMS in the first one, is that there was a trend toward lower adherence for this last regimen that was a higher pill burden. So it was 6 weeks, but these were the patients that were taking 3 pills, 2 in the morning, 2 in the evening. So it's lower, but it wasn't statistically significant. But you did see that there was that trend for that adherence decreasing. And this is just specifically the data from that electronic monitoring system. And they also looked at a trend similar for just the 12-week period. So this is essentially Harvoni for 12 weeks, and they checked in with the patient sometime at 0 to 4 weeks, 4 to 8, and 8 to 12, and they noticed that the adherence started to fall off after the first half, essentially, of treatment. So again, it's still pretty high. It's still above 95%. So adherence is still good, but it kind of wanes after, you know, the midpoint of therapy at this point. And they only did this for the 12-week treatment. They didn't review that with the 6-week because it was already shorter. And then this is a different study. This one was published in 2019, but the data was from 2016 and 17 that they looked at non-adherence for DAAs as well. And they wanted to evaluate non-adherence factors in general, but they also wanted to specifically target non-adherence in patients that had, looking at, I guess, subgroups of patients with and without mental health conditions, alcohol use, and substance abuse. So they teased out, different from the previous study, they teased out who was abusing just alcohol and those that just had drug abuse. So the reason that they wanted to look at these subgroups is because, you know, the various insurances saying that these patients, you know, refusing to authorize medications for patients with drug and alcohol use just because of the risk of non-adherence for those patients, as well as some provider surveys that have been done and published in other studies where these are sort of the targeted groups where they were apprehensive to start treatment because these patients might not complete therapy or might be non-adherent to their therapy. So there were like 1,500-ish participants in this study. So when they looked at it, some of the things that I want to highlight is that they met with patients somewhere in the neighborhood, they gave themselves a couple-week window, but somewhere in the neighborhood of treatment week 4, and also in the neighborhood of around end of treatment, but somewhere like they said 2 to 3 weeks before the end of treatment. So they're looking, you know, testing adherence at that treatment week 4 in the end. And these were all regimens that were 12 weeks. There were no 8-week treatments in this study. So some of the predictors of non-adherence that they found were towards the end of treatment. So everybody was similar at that treatment week 4 point. So they didn't find any differences in adherence for any of the subgroups with or without mental health conditions, alcohol, or drug abuse, and any of the other kind of demographics and other factors that they were evaluating. But when they did find those predictors of non-adherence, it was the ones that kind of waned after treatment week 4 when they were looking at them around the end of treatment. So those predictors were alcohol use specifically, so not mental health conditions and not substance abuse. Patients younger than 35, those that were non-white, and those that, based on a symptom severity scale that they provided, had a higher symptom burden. And they also highlighted 2 of the regimens. So the first one here is umbitasvir, paritaprevir, boosted with ritonavir, and disabuvir, which is Vicira, which is not really recommended anymore. It has a high pill burden, a lot of side effects, a lot of more drug interactions. So we don't see this used as much. So I was not surprised when this one came up as more non-adherence just because of the pill burden and all those factors. What was interesting in here was that Grisoprevir and Elbasvir combo, which is Depatir, this medication also was one of the ones that they said there was more non-adherence with this regimen. Now, if you tease into the data, some of the stuff that they found is that a lot of these patients were also falling into these other categories of being non-white, having higher symptom burden, and some other things that they teased out. So this one, still kind of up in the air. I'm surprised by that one, but was not surprised with the Vicira version in that one. And then they specifically reported why the patients said that they were non-adherent. And I wanted to highlight this because just anecdotally, when I talk to patients, these are the same things that they're telling me when they miss doses. So most of these are the unintentional. They fall into that unintentional non-adherence category that we talked about. So this is not part of their normal routine. So a lot of them just, forget every once in a while. They they go to work and they forget to take their medication. So a lot of these are very common things that I'm hearing about. So it was kind of interesting and nice to see that the patients across the board, this is their normal reasons for non-adherence. So how do we overcome those non-adherence is a lot of education. So making sure the patient understands the disease. So here, hepatitis C, what it can do to them long-term and what the benefits are of being treated, and going over the medication so they understand everything, have expectations, and then have that buy-in. So I like to review the patient's goals for their treatment. And when I say that, it's very easy for me to say, yeah, they want to be cured of their hepatitis C, but we really have to, sometimes just say, like, what is your goal? What do you want to get out of this? And a lot of them will give you things like, I don't want to transmit this to my family, or I want to have a baby soon and I want to make sure the baby doesn't get it. So yeah, that ties back to being cured, but we can use that as a motivational tool to make sure the patients are adherent. And then upfront, are there any potential adherence barriers that we can take care of, or at least identify, so that we can make more interventions, and then tailoring the regimen to that patient's needs. So a lot of times I'll get asked, like, what's the best regimen? What do you recommend? Well, I know what I would pick for myself, but the patient might have other things. Like for Mavorite, for example, if a patient doesn't eat regular meals, that might not be the best option for them because they do need to take that with food. Or the PPIs that we talked about today, and having to change their normal dosing schedule because they're taking other medications where now we need to change things up. So other things are then, once they're on therapy, identify what their non-adherence is, and then based on the examples here, what can we do to overcome that? There's also some literature that shows more frequent communication with the healthcare provider helps, because they're more adherent in the week before and after they meet with their healthcare provider. So when you're able to meet with the patients, being able to help encourage them if they have non-adherence, and then provide them with additional resources that we can use. So in the interest of time here, because I'm already over, some methods to help with adherence is, key, finding out what the reason is. So you can look on the slide here is, try to get a routine and help them with different options here for patients that just forget. And if there are concerns or side effects, and this is the intentional, they don't want to do it, counsel them on what to expect and what they can do to work around those side effects to avoid them. There's also some data that shows having an interdisciplinary team helps patients with adherence. So they always have somebody to reach out to that's going to help them with their Medicare issues, to afford their medications, answer their questions, and make sure they get their refills on time. And then the complexity of the regimen, so the easiest regimen for the patient. And that's where you're going to get the patient engaged to be able to make those decisions. And then on the slides here, I have some of the adherence packaging that some of the manufacturers have. The great Dr. Greg Peters has termed these the advent calendars of hepatitis C. So this helps them remember where they are in therapy, whether they've taken their dose, to kind of keep track. So for Mavorite, they put each week in its own box, and then they can pull out, this is perforated here, pull out each day's dose and go ahead and take it, since it is multiple pills a day. And then Depatir has a nice schedule here. It's got arrows for them to follow along so that they can keep track of where they are. I've also got the generic Harvoni and Epclusa packaging here. It's in blister pack, so it's kind of like adherence packaging, because at least the patient can eyeball and see how many they have left compared to a bottle where they don't really know how much they have left. So this sometimes helps patients keep track, because I'll talk to them and they'll say, I have a strip left. Well, I know exactly how much that is. And I didn't go into too much with financial assistance. So in short, this should not be a reason patients can't take Hep C medications, because we have a lot of ways to overcome that. So don't let your patients not take it because they can't afford it, because there's lots of copay assistance programs and things that can help with that. And then there's my references. Sorry for going over, guys. Anybody have any questions?
Thank you
Great,
so much.
great, that's awesome.
No apologies ever. Thank you so much. Any comments or questions from the group? Brian, I noticed you unmuted there.
Yeah, Rachel, this is Brian Thompson. How you doing?
Good, are you?
Pretty good, pretty good. Really good presentation. Actually, I may send you an email to see if you'd be interested in speaking at our Eastern Medicaid Pharmacy Providers Association in November, because you know, I'm involved in this hepatitis C elimination plan, and one of the things that we are battling constantly is patient adherence, and it's very frustrating to see you know, appeals for retreatment of patients where they didn't fail treatment, they failed to take their treatment, and then they have to move on to another regimen that's more expensive. And you know, that's one of the primary reasons we are not, or at least I'm not willing right now to remove a PA entirely, because I feel like we need to have some sort of stop to look at what's going on. And most of our criteria, I think, is kind of to label, but really trying to get providers to realize that they play the major role as being the last to see this patient, to counsel them and make sure that they understand the value of their regimen. Like, I don't want to be tacky about it, but telling them they've got $24,000 in their hand might make them more willing to not think that this is an inconvenience for them to take outside their normal schedule. But anyway, I really like the points you made, and so I'm interested, if you are, and maybe having you speak. Another thing I was going to say really quick, I just actually got a call from the Board of Pharmacy, and this is kind of loosely related to adherence, but I kind of look at substance abuse and hepatitis C and HIV from sort of the same perspective. You've got a lot of overlap in those patient populations. And so adherence is really critical for all of those to really work. But they're also really expensive meds. And, you know, for my role, I have to worry about expense, unfortunately. And so we're getting reports of patients, you know, we made Sublocade a preferred agent to try and get improve adherence, and also there's a lot of stakeholders that like the idea of not having to monitor, you know, dosing and things, making sure patients take them. So Sublocade, just for reference, is roughly $1,200 a month versus $60 a month for Suboxone. And we've had an increasing number of patients, reports of patients not showing up after Sublocade was shipped to a facility for administration. So somebody's got to eat the cost of that, because apparently the laws right now do not allow Sublocade to be returned to the shipping pharmacy. I'm trying to figure out why that is, but that's what Krista Capehart just told me. And so similar issues with the Hep C.